Now it's time to move to auscultation of the abdomen. Of course, if you remember your normal sequence of assessment, we do auscultation last. But in the case of the abdomen, we auscultate before we touch, whether it's percussion or palpation, because both of those can actually interfere with the normal bowel sounds. Specifically, they usually will increase the frequency of those bowel sounds. So we could interpret our findings as hyperactive bowel sounds when actually the patient is perfectly healthy and normal. When we auscultate, we'll use the diaphragm of the stethoscope for bowel sounds, and we'll use the bell to assess for vascular bruits. When we listen for bowel sounds, one of the most important things we want to know is the frequency. You can actually count how many sounds you hear per minute, and the normal range is 5 to about 30 sounds per minute. Now, once you're an experienced nurse and you start to know what normal sounds like, a lot of people don't officially count until they notice that, there really aren't very many bowel sounds, and then they might actually make a count of that. Or, of course, if there are loud, frequent sounds, we can also make a note of that. We'll also note the character, what those sounds are like, especially if they're in abnormal frequency as well. If we have loud, prolonged gurgles, what people say their stomach is growling and you can hear it without a stethoscope, that's called borborygmi. So make sure you know that vocabulary word. When you start to assess, most resources recommend that you start in the right lower quadrant, because this is the quadrant in the abdomen where you are most likely to hear bowel sounds. So if you start there and hear anything, then you know we've got at least some kind of activity in the stomach, and then you can move to assess the other quadrants. If you start there and you hear nothing, then you know you're very unlikely to find bowel sounds in the other quadrants. If we find unusual bowel sounds, increased bowel sounds usually mean anything from hunger to a GI bug, gastroenteritis, or even a bowel obstruction. If those bowel sounds are also high-pitched and what usually people describe as tinkly, then again, we're pointing more towards the bowel obstruction. If we have decreased bowel sounds, then this most often means either peritonitis, which is inflammation of the peritoneum, that whole abdominal cavity, or what we call a paralytic ileus, where peristalsis in the intestines has just stopped. This happens frequently after abdominal surgery, so it is something you should be aware of, especially with your hospitalized patients. If you are going to chart that your patient has absent bowel sounds, this is actually defined as no bowel sounds for 5 whole minutes. So if you're going to do absent bowel sounds, then you need to stand there and listen for 5 minutes to make sure you really hear nothing. And if you really don't, it is considered an emergency because it's a sign of a complete intestinal obstruction, and you need to get the surgeon on board to help fix that. When you listen for vascular sounds in the abdomen, remember to use the bell of your stethoscope, and then you can move throughout each of these landmarks, and we're just listening for a bruit. We may not hear a pulse, we may just hear bowel sounds, so make sure you don't get the bruit and the bowel sounds mixed up. Remember that a bruit will be a steady rhythmic swishing noise, while the bowel sounds are random clicks and gurgles. Remember from our discussion of vasculature that you may also be able to palpate a pulse at each of these locations. Okay, that does it for abdominal auscultation. Next, we'll move on to percussion.